What is going on, everybody? My name is Alec, and today we're going to be going over the EMT patient assessment. Here we go. Alright, so there are four main components to the assessment. We're going to have our scene size up, primary assessment, secondary assessment, and reassessment. Jumping right in, the first section is going to be scene size up. This is basically going to be taking the information that we're getting from our dispatcher, and we're going to be thinking about what is going to be going on scene, maybe what equipment we might need, if there's any hazards, what's going on with the patient initially, what's their chief complaint essentially. The first part of this is going to be BSI. This is going to stand for body substance isolation, and just like it sounds, we're basically going to be isolating our own bodies from the hazards and whatever's going on with the patient. This is going to be your gloves, gowns, masks, turnouts for firefighters, helmets, anything that's keeping you guys safe when you're on scene. Next part of scene size up is going to be PENMAN, and this is another acronym for you guys. You'll notice that so much of learning EMS or about EMS, emergency medical service stuff, is there's so many acronyms involved. It's actually pretty nice because it makes the information way easier to digest, and it gives you kind of a systematic approach where it's really hard to forget aspects of your assessment when you're running through it. The first part of PENMAN is going to be the P, and this is going to stand for personal, partner, and patient safety, and it's going to be in that order for a reason, because obviously we need to protect ourselves and our partner, because if we can't do that properly, then we're not going to be able to help the patient. So it's really important that you guys keep that in mind. Next part of PENMAN is going to be the E. This is going to stand for environmental hazards. This is really important to think about before you even get on scene, to think about actually where you're going. So is the call going to be on a freeway? You're going to be thinking about cars passing by that can be more dangerous. If it's at a house, the patient could have dogs. It could also be things like the weather. Is it raining, thunder and lightning? All these things are going to factor in and affect patient care. The next part of PENMAN is going to be the N. The N is going to be number of patients. Typically, it'll just be one patient, but there are obviously those off cases that there's going to be maybe a traffic collision. You're going to have 2, 3, 4 patients, and there might need to be additional ambulances called at that point. Next part in PENMAN is going to be the M. This is going to stand for mechanism of injury / nature of illness. So to break both of these down, mechanism of injury is going to actually be looking at the mechanism behind the patient's injury. So this is going to be things like, did they fall and then they injured their hip, or they broke like an arm or something. Essentially not really medical related, whereas nature of illness is going to be something more like hypoglycemia, where their blood glucose is low and they might be unconscious because of that. Super important point for you guys with M. I just want you guys to realize that mechanism injury and nature of illness are not isolated from one another. What I mean by this is that the mechanism of injury can actually cause the nature of illness and vice versa. To give you guys an example, I remember my partner and I showed up on scene one time to a traffic collision, and we saw the spider cracked window right when we got there. That's a severe mechanism of injury, because that means that somebody's head actually hit the front of their windshield so hard that it cracked it. But we later figured out is that the patient actually had a seizure while they were driving, so that's the nature of illness. So in this case, the nature of illness actually caused their mechanism injury for them hitting their head. The A in PENMAN is going to be additional resources. This ties in really well with what I was talking about earlier with the number of patients. If it's a traffic collision, we might need more ambulances, we might need ALS for something like that. You know, if the scene feels unsafe, if you're going to a GSW, gunshot wound, or a stabbing, you're gonna really want the police department to clear that scene before we get in there and start helping the patient. Last but not least, in the PENMAN section, we're gonna go with N, which is gonna stand for need for extrication and spinal immobilization. This is going to be dealing with patients that are trapped, for instance, in their car. You guys might need special tools to actually cut their doors off and get them out. Spinal immobilization, this would be, did the person suffer a severe fall, or they're having neck pain, or, you know, a lot of times in traffic collisions, people will get some form of whiplash. and you'll want to throw a C-collar on them just to play on the safe side with maintaining neck stability and obviously preserving their cervical spine. Moving right along through the assessment, we are going to jump into the primary assessment. The goal of the primary is essentially to find and rapidly treat any life-threatening conditions that are going on with our patient. The first part of the primary is going to be to form a general impression. So this is going to be when we're actually walking up to our patient and we're actually visualizing them. So we're going to be kind of making a mental note of things like their age, sex, position found, MOI, NOI possibilities, and are they stable or unstable currently? Are they in, a life-threatening situation? Next part of the primary is going to be another acronym for you guys because I know how much you love them. It's going to be AVPU, and this is basically going to be testing the patient's level of consciousness, or LOC, as we call it in the field. The first part of AVPU is going to be the A. This is going to be checking, is the patient awake and alert? And we check this by seeing, are their eyes open, and are they tracking us as we walk up to them and introduce ourselves. The V in AVPU is going to be verbal stimuli. So this is going to be, for instance, if their eyes aren't open, we might call out to them, say sir or ma'am, or if we already know their name at this point, if family's on scene, we might call them by their name and see if they respond to that stimulus. So if our patient is not alert and they're not responding to verbal, we're going to go ahead and move on to the P in AVPU, and this is going to be painful stimuli. For this, there's multiple ways, I guess, to inflict painful stimuli. Typically what you'll see is what's called a nail bed pinch, and it's actually going to be pushing your finger into their cuticle part of their nail. I typically do what's called a sternal rub with my knuckles on their chest. Some people also do a trap pinch. All of them work, obviously, to see if the patient responds to painful stimuli. The last part in AVPU is going to be the U, and this is going to stand for unresponsive. This is basically going to be if the patient didn't respond to both verbal and painful stimuli, then we're essentially going to classify them as unresponsive. And I will go through right now essentially the steps that you take if you end up running through AVPU and the patient is unresponsive. If we find that the patient's unresponsive, we're going to go ahead and immediately check a carotid pulse. So we're going to use 2 fingers. You do not want to use your thumb when you're checking pulse at all. This goes across the board because your thumb actually has a pulse, so you might actually be feeling your own pulse if you're using that on the patient. So use 2 fingers. We're going to go sort of right in the jugular right here. We're going to be checking the carotid artery on the patient. After we check the carotid, and let's say for the sake of this example, we do not feel a carotid pulse on this, we're going to immediately start CPR. This is going to be cardiopulmonary resuscitation. This is going to be the 30-to-2 ratio of 30 chest compressions and 2 ventilations for the patient. And this is going to be actually the first thing you essentially learn in your EMT class, is getting CPR certified. So we're going to start CPR. So one of you guys is going to start doing chest compressions, while the other is getting the AED set up, which is automated external defibrillator. For the AED, we're going to be placing, for adults at least, we're going to have 1 patch on the upper right portion of their chest, and the other one's going to go on the lower left quadrant of their abdomen. You'll typically see on the AED, it'll have diagrams and pictures. It'll show you exactly where to put the patches. For children, we're going to put 1 patch on the front of their chest and then 1 on the back. And this is going to be pads that are specific for pediatric children patients that are going to be younger than 8 years of age. And after that is set up, we're going to have to start breathing for the patient, because if their heart is not pumping, they're not going to be breathing either. To breathe for the patient, we're going to be using a BVM, what's called a BVM. It's going to be a bag valve mask. It's going to be this mask that fits over your patient's nose and mouth, and then you're actually going to be pumping this bag, sort of like air sac, that's going to be on the device, that's going to be pushing in air to their lungs and breathing for them. And this, most of the time, has to be hooked up to an oxygen canister. I have seen some fire BVMs that don't need to be hooked up, but most of ours that we use, you have to hook them up to 15 liters of oxygen via that canister that's going to be hooked up basically by this hose that goes into the end of it. Continuing with this example, so we got CPR started, we got the AED properly attached to the patient, we're breathing for them. At this point, the AED is going to be turned on. It's pretty much just going to be talking to you the whole time, so it's going to be like telling you exactly what's going on. And the AED is basically going to be checking the patient's heart rhythm, and it does a really good job at doing this. It's looking for 2 abnormal rhythms that the patient could be in if they're in cardiac arrest. That's going to be a ventricular fibrillation and pulseless VTach, or ventricular tachycardia, essentially where their heart is pumping so fast that it's almost just quivering and it's not adequately distributing blood through the rest of the body. Common misconception that you guys will see in a lot of shows or just from hearsay from people is that you'll see when, so say like the EKG is running flatline is what we call it, or asystole, so they essentially have no rhythm. Typically you'll see that those patients will get shocked in shows and it'll bring them back to life. Unfortunately, that's not how it works in the real world. For that to be more accurate, it would be in what I just mentioned, the rhythm would look like VFib or VTach, because those are shockable rhythms that can bring it back to the sinus rhythm or normal rhythm that we're used to seeing. Another super important thing that we're gonna need to worry about when someone is in cardiac arrest or full arrest is maintaining their airway. Sometimes what happens with these patients, especially when they're lying supine or on their back, is that their tongue actually relaxes and they can actually choke on their own tongue. There could also be, if they suffered some sort of trauma, they could have blood or teeth in their mouth that's blocking their airway. I've had patients that have thrown up, and so they have some vomit that's stuck in their airway and it's not letting me properly breathe for them with the BVM. So what we use is suction to get that out of their airway and clear it out. And then once that happens, we use either an OPA, so an oropharyngeal airway device, or a NPA, nasopharyngeal airway device to maintain patency, is what we call it, for their airway. Last part for full arrest patients is we're gonna wanna get them to the nearest hospital as soon as possible, and hopefully at this point you guys have requested ALS follow-up because the patient might need to be intubated, which is out of the EMT scope of practice. That's paramedics' forte. So we're gonna let them do that. They're also gonna be pushing some drugs, for example, epinephrine, and then we're also gonna probably be giving them fluids because they might be pretty hypotensive at this point. So that'll all be kind of going on while we're getting this patient to the hospital, code 3 lights and sirens, as quick as possible. Throughout this whole process, we're maintaining CPR, maintaining that airway, and doing compressions. Sometimes you guys will have to do it for over 20 minutes, and obviously monitoring their vitals throughout this whole process. We'll go through obviously the rest of the assessment of stuff to do, but that's just kind of a precursor of the different avenue that you can take with AVPU for an unresponsive patient. I will also mention that if a patient is unresponsive, it doesn't necessarily mean that they're in full arrest. So I took you guys down that route, but let's just say you did go and check and they had a carotid pulse. At this point, we're gonna move on with our assessment to our A, B, C, D, E, F, and I at this point. Moving on, so the A in ABCs is gonna be our airway. One of the things that stuck with me that my instructor would always mention is airway is king. And there's a reason for that, because if the airway is obstructed, then that means that the patient is not getting adequate air into their lungs, and then if they're not getting into their lungs, they're not getting into their tissue. Your brain can only go about 6 to 10 minutes without oxygen before permanent damage starts happening. So that's the reason why it's one of the top things on the primary assessment, is because we need to stop and make sure that that's patent before we move on to anything else. So if the patient is alert, talking to us, that's going to be a patent airway. If, for instance, they're unresponsive, we check this through a modified jaw thrust maneuver if we suspect that the patient has suffered some form of trauma, because we don't want to be tilting their neck back because they could have damaged their cervical spine. If we suspect that they didn't suffer any trauma or it doesn't appear that way, we're going to be using the standard head tilt chin lift maneuver, where we're actually going to be tilting their head back, and that's going to be maintaining that straight airway out to their mouth. Next thing in primary is going to be the B in ABCs. The B is going to be breathing. We're going to be looking at the patient's rate, tidal volume, their depth, how much air are they getting in? Are they taking really rapid ventilations? Are they hyperventilating? Or are they taking really shallow, slow respirations? If they're taking really slow, we're going to have to assist in breathing. And if they're taking really fast respirations, which we see in a lot of anxiety sort of related patients, we need to obviously calm them down and get their breath back to the normal adult 12 to 20 respirations per minute rate. A quick side note for the B in breathing for our assessment. We really want to take this seriously, obviously for all of our patients, but especially for children, because if they are having some sort of breathing issues, children can actually go into a very serious state, typically cardiac arrest, very quickly, so they rapidly deteriorate when they're having issues with their breathing. So for children and adults, we're going to be checking lung sounds. So we're going to be listening for stridor, wheezing, any of those lung sounds that you guys are going to learn in your class, and you guys will probably get to hear what they sound like. Definitely keep that in mind, especially on children. Next, in our primary, we're going to go over C in ABCs. C is going to be circulation. So this is going to be looking at COPS, so COPS. C is going to be their capillary refill. O is going to be their obvious signs of bleeding. P is going to be pulse, and S is going to be their skin signs. So for cap refill, what we are going to do to check this is we are going to, again, look at the finger. We're going to squeeze down on their finger. Let's see if I can get a little more in focus for you guys. There we go. So if we're going to squeeze down on the finger, and you'll notice that there's kind of a pinkish part to our nail. And what happens when you squeeze down, it kind of turns white, and then when you let go, it turns back to pink. And so we want that change from, pink white to pink to be less than 2 seconds, because that means that they're getting adequate perfusion to their extremities in my hands. So that's how we're going to check, is by just checking their nail. Super quick, and typically you'll notice with a lot of patients it'll be under 2 seconds. O is going to be obvious signs of bleeding. We're going to be scanning obviously their body. If the call comes out as a bleed, that's going to be pretty much the #1 priority after we've checked airway and breathing. Let's say they have a laceration to their arm. At this point, we're going to see it and treat it. So we're going to apply direct pressure to that. We're going to elevate it above the heart. After we do that, let's say if they continue to bleed, we might have to put a tourniquet at some lower portion of their arm to control that bleeding. When a patient is presenting with something that there's a problem, that we spot within our assessment, that's when we stop and we're actually treating the patient in that instant. So we're not running through all of our assessment and coming back, because the assessment's laid out in a way that you're addressing most important to the lesser important. As I mentioned, the primary assessment's goal is to identify and treat any life-threatening conditions that's going on with the patient. So if they're actively bleeding from their arm, that's something that we need to stop and address right away. Next part in circulation is going to be the P, which is going to be pulse. I check the radial pulse. You're going to notice it on the thumb side. You'll kind of, when you tuck it in there, you'll feel a little bit. For this, you just want to check the pulse for about no more than like 15 seconds. We're just kind of feeling for any irregularities. And you'll get used to kind of feeling a pulse for a couple seconds, and you'll kind of know that it's already tachycardic or bradycardic. But this is just to check if it's strong, regular, if it's weak, thready, because again, that could be identifiers for, again, more serious things going on with the patient. But for this portion of it, we're not taking the full pulse. We're just doing it for about 10-15 seconds. Last part in the circulation is going to be looking at the S, skin signs. So we're going to be looking at the condition of their skin. Is it normal, warm, and dry? We're going to be checking temperature, moisture. What does it look like? Ideally, we want a patient that's normal, warm, and dry, but sometimes we'll have patients, for instance, that are in shock, where they'll be cool, pale, and diaphoretic. So their skin will actually feel cool to the touch. They'll look pale in complexion, and they'll actually be sweating, or we call it their diaphoresis or diaphoretic. So you can actually like see that they're profusely sweating. And again, this is a indicator of something serious going on. We don't necessarily have to identify what form of shock it is in that instant, but there is steps that we take. So again, we're stopping and we're seeing and treating their condition. So at this point, we're gonna put them in shock position. So we're gonna elevate their legs, and we're gonna put a blanket on them because their body temperature is cold, and we're gonna go ahead and give them oxygen to all these patients, because whatever form of shock they're in, their body's not adequately perfusing, which is what shock is. So we need to give them oxygen to supplement that and hopefully get those extremities with more oxygen to them. All right, so after we've gone through our ABCs, we're gonna move on to D, and let's say for the sake of this example, everything checked out. So their airway was patent, they're talking to us. Breathing is 16 respirations, adequate tidal volume. C, circulation, everything looks good. Cap refill is less than 2 seconds. We don't see any obvious signs of bleeding. The pulse feels normal, strong, and skin signs are normal, warm, and dry. We're gonna move on to D, which is going to be looking at deformities and deficits on our patient. And this particularly falls under a lot of people that have had previous strokes. So they might have, let's say, left-sided deficits because they had a stroke on the right side of their brain where they can't move their left side as well as their right. So typically we can ask the patient or family member, does the patient have any deficits from stroke? We're not gonna ask the patient if they have any deformities straight up. We're just gonna kind of scanning their body and checking for that. But definitely ask about the deficits, because that's gonna be important as we go through our assessment, that you're not mistaking old injuries or deficits with new ones. That's gonna be really important for determining, the priority of getting the patient to the emergency room or not. Next portion of the primary is gonna go over E. This is gonna stand for expose, visualize, and palpate. For the sake of this example, let's say our patient is presenting with abdominal pain. So we're gonna expose the abdomen, we're gonna visualize it, for instance, as the abdomen distended or kind of bloated, and then we're actually gonna palpate the region, which essentially just means we're gonna be applying pressure to it. And for the abdomen, we typically kind of have this double-handed motion. We kind of glide from left to right, checking all 4 of the abdominal quadrants. Let's say they're complaining of periumbilical abdominal pain and it's painful to palpation. So that's gonna be something that we're gonna be telling the triage nurse when we get to the hospital, that it actually hurts to press on that area. One severe condition that someone could have is something called a AAA. And this is typically gonna be seen in the lower left quadrant of the abdomen that you guys will learn about in your class. And it's actually gonna be like a pulsating mass on the patient's body. If you see that when you're visualizing it, we don't really wanna be palpating that area, because that thing could be, one poke away from rupturing and the patient's gonna bleed out within a couple minutes. So if you ever come upon that, it's pretty rare, but if you do come upon that, we're gonna be skipping the palpate portion of that and getting this patient to the emergency department as soon as possible. We've made it through A, B, C, D, E, and now we're moving on to F, which is gonna be formulate a field impression. And this is basically going to kind of be going back through everything that we've run through in our primary so far. To give you guys an example, let's say again, we have that 50-year-old female. She was found in the tripod position. MOI, probably not. NOI, she might be having some difficulty breathing. She doesn't appear to be in a life-threatening condition, but she still needs to go to the emergency department. Next, airway is patent. She's talking to us. She is breathing, let's say, pretty rapidly. She is in the tripod position, which is a typical stance that you'll see people having a difficult time breathing. And let's say she's getting adequate tidal volume. She's only speaking to us in, let's say, 2 to 3 word sentences. So she is pretty short of breath. She's having a difficult time breathing. Circulation, let's say everything checked out. All of her circulation looked normal. Doesn't have any deficits, no obvious deformities. For this, we don't really have to expose, visualize, and palpate necessarily if she's just complaining of shortness of breath. But as I said, the examples earlier, it would fall under that. So that's kind of formulating a field impression. A lot of times what we use this for is, for example, the area that I run in LA, we run with fire a lot. Actually, every single call we run with fire. But sometimes we're first on scene. And so we do all the BLS assessments. They do the ALS assessments. And let's say if my partner and I are first on scene, we're gonna be running through our assessment, gathering all this info. And when the paramedic gets there, we're just gonna give them a quick run through. So kind of stuff that, through our assessment that we found, we're gonna be verbalizing that to the paramedic just to give him a rundown of what we got so far on our assessment. So that's kind of the significance of formulating that field impression. You guys will get really good at doing this as you practice it more about, what specific things you're looking for in each case with patients, what's important information, not so much for others. So just keep that in mind. Last but not least, in the primary is going to be I. So we have A, B, C, D, E, F, and I. Is going to be that last letter in the acronym. And this is going to be identifying the priority of the patient. So does the patient need to go to the hospital right this second? Or, is it something less severe where we can actually move on to our secondary and do that where they are, let's say in their house, or do we need to do that in the ambulance on the way to the hospital? Moving through our assessment onto the secondary assessment, this is where we're basically going to be delving deeper into what's going on with the patient. So we're gonna be asking them a series of questions, looking at their medical history. We're gonna be taking a full set of vitals on the patient at this point. And if it's the right case, we might be doing some sort of rapid physical exam on the patient. You guys will probably learn this in your class, but typically what happens is there's gonna be 2 EMTs on the ambulance. And so through all of this, you guys will essentially be kind of helping each other out, especially in the secondary. For instance, like my partner and I usually do the question asking, and my partner will take the vitals. Sometimes we'll switch, or we'll do it kind of simultaneously to kind of catch each other, make sure that we get everything. We need to learn how to do both of them well. So you can be in either situation and do it. All right, we are on to our sample. So sample is going to be the S. Started out, we're going to be the signs and symptoms. So this is going to be the patient's chief complaint. So why did they call 911? You're probably going to have an idea of what their signs and symptoms are at this point from the primary assessment. But if you don't really have a super good idea, you can always ask the patient again. So why did they call 911 in the first place? What's bothering them the most? That's gonna be their signs and symptoms. An important differentiation between the two, signs is actually something that we can visualize. So let's say, they're breathing really quick, so that's a sign. A symptom might be something like a headache. It's more subjective, is what we call it. So that's going to be something that's going on with the patient that we actually can't visualize it, but the patient is telling us, hey, I have this head pain or I have a headache, whereas sign is going to be more objective. So that's something that we can visually see with our eyes. Moving on in our sample, we're gonna go to A. This is gonna be looking at the patient's allergies. This is gonna be, anything from foods, bugs, drugs. And we're just gonna ask the patient, do you have any known allergies? What I typically like to do is kind of start just throwing out examples for my patients. So, penicillin's a pretty common one. Any food allergies, kind of just ask them, prod them a little bit, see if they can remember. A lot of times the hospitals will have it on file if they've gone to the same facility, but it's definitely a good idea to ask them again so you have it for your own assessment, and they might have a new allergy that's going to be added on at the hospital. M in sample is going to be medications. So this is going to be asking the patient again, are you currently taking any medications? I usually don't generalize my questions like this because sometimes when you have older folks, they're going to tell you, yeah, I'm taking, vitamin C, D, omega, blah, 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 all that stuff. So a lot of times in my case, we actually do something called HAM. So we do history, allergies, and meds in that order instead of sample. You guys definitely need to learn sample because that's going to be what's going to be your class is going to be testing you guys on. But I like HAM a little more because, I'll get their history, I'll get their allergies, and then I'll get their medications. So I can be like, let's say they have high blood pressure, so hypertension, and diabetes. So I would say, hey, what are you taking for your high blood pressure? And that might be, Lasix, lisinopril. You guys will learn the kind of drug names as you go. And then for diabetes, are you taking metformin, insulin, stuff like that? It's gonna make your guys' assessment a lot cleaner, and it's not gonna jumble up the patient's responses a bunch for not necessarily unnecessary info, but it could be info you don't really need. So just keep that in mind. You can ask them a general question after that, like, hey, are you taking any other medications aside from Lasix and insulin? But, just start it out, maybe be very specific, because then they'll kind of kind of be able to catch on at that point a little more, hopefully. Moving along, we are at RP. This is going to be pertinent medical history. So again, what sort of medical problems does the patient have? Pretty common: high blood pressure, hypertension, diabetes. Some patients have had previous strokes, myocardial infarctions, heart attacks, all that stuff. So we want to really get an overall view of the patient's medical history, because the hospital particularly will really be asking for that. L is going to be last oral intake. I typically don't ask my patients this because it seems kind of irrelevant, but you guys are, again, going to be running through this class. You need to at least verbalize that you know what L stands for when you're running through your sample. So we're going to ask the patient, when's the last time you had anything to eat or drink? The only significance I can really think of for this would be if the patient has to go into surgery. You know, the hospital might need to know that, but then once you get to the hospital, the nurse and doctor are going to ask them that. The other case, I guess, that I use this sometimes is when we have nausea, vomiting patients with maybe abdominal pain. Of ask them, do you think you might have gotten food poisoning from something? Like what's the last thing you ate? And kind of bring it up in that context. But most of the time, you know, if the patient's having like chest pain or something, it's kind of irrelevant at that point. Last thing in our sample is going to be our E, and that's going to be events leading up to what's going on in the situation. So you can ask them, what were you doing before this came on? So were they just sitting on the couch? That would be like a sudden onset of chest pain. Or did they go for a jog, you know, or were they mowing the lawn or gardening or something? So this is really important to get that info from the patient in that case. And this will kind of just come in with the whole story. You know, the patient will be telling you, you know, this has been going on for 3 hours or 30 minutes or 10 minutes ago, right before I called. So it's really important to get that timeline, because as I said, especially for something like chest pain, we're really going to want to know when those signs and symptoms started. Simultaneously, your partner will probably be taking a full set of vitals, but for our assessment, we are going to have to do everything in front of the instructor. So we are going to use another acronym so we do not forget any of our vitals. This is going to be BELLSRP. So we're going to start with the B, which is going to be a blood pressure. We're going to be looking for the systolic and diastolic pressures. The systolic is going to be the first heartbeat that we hear. Diastolic, is going to be the second one. What I typically do with a manual blood pressure is I'll pump it up, the pressure, which is in millimeters mercury or mmHg. I'll typically pump it up all the way to like about 200, 220, which is pretty tight. At that point, I'll leave it for like half a second, and then I'll start slowly letting air out of the valve. And what you're doing is you're listening with your stethoscope for that first heartbeat, because what the cuff is doing is actually closing off the brachial artery. And what happens is when you slowly let air out or lower the millimeters mercury, it actually slowly opens up that brachial artery. What happens is that systolic is going to be that first noise that you hear, you know, as you let out the pressure. And let's say you're letting it out, you're not hearing anything, and then at like 120 you hear that first beat. So cool, that's systolic, 120. And then you keep letting it go out, and boom, you hear the second one at let's say like 76. So that blood pressure is going to be 120 over 76. Super important note for blood pressure: please do not make up blood pressures. It's one thing to do that in the classroom in a safe environment. When you get out in the field, people's lives depend on you to get an accurate reading of all their vitals. So if you're just throwing out 120 over 80 and the patient, let's say, is hypotensive at 70 over 40, the person's not going to be receiving the fluids or something in pre-hospital care that they need in that instance, which they could actually die from going into shock. So if you can't get a blood pressure, just verbalize it. There's nothing wrong with that. Sometimes it's really hard to get blood pressures in the field. Just verbalize that and, you know, let someone else give it a go. But just please do not make up blood pressures. Next, in BELLSRP, we are going to be checking the E or the I's of the patient. And for this, we're going to be using another acronym within this acronym, and that's going to be PEARL. So we're going to be checking for the pupils are equal, round, and reactive to light. Typically to do this, we're going to be using something like this. It's going to be like a little pen light for you guys. Let's see if I can get it in focus. My pen has a little click-on thing. See that? So we'll be checking the patient's eyes. You don't really want to be holding it next to their eye for a super long time. You'll be able to check it pretty quick. You don't want to blind the patient, obviously, so it's going to be very quick. You don't want to be super close to their eye like I just was either. You want to be a little distance away. Just shine enough light where you're going to see those pupils will actually constrict a little bit to the light, and then they're going to dilate or get bigger once the light goes away. The first L in BELLSRP is going to be lung sounds. This is where we're going to be actually auscultating, is what we call it, or listening to the lung sounds. We're typically going to check a couple spots on the body and on the back as well, just to make sure that there's no wheezing or any other signs of difficulty breathing in their lungs. We want them to be clear bilaterally. The second L in BELLSRP is going to be going back to level of consciousness. We're already going to pretty much have a good idea of their level of consciousness at this point, but just to double check, we're going to be asking them person, place, time. Some counties, not LA County, but some counties do event, so it'll be person, place, time, event. So you're gonna ask them, patient, what's your name? Let's say they answer it correctly. We're gonna ask them, where are you right now? Or do you know where you are? Let's say, okay, I'm in my home. Great. What city are you in? We might say Los Angeles. Time, do you know what month it is? Or you can ask them an event, which could be like, what holiday did we just have? Or you could say, who's our current president? Stuff like that. So all of them are gonna be assessing their level of consciousness. And let's say our patient answered all those questions perfectly. We're gonna say A and O times 4. Each one is 1 point essentially on that. So A/O, alert oriented, times 4. So they're alert and oriented, person, place, time, and event. If they are altered, then that number is gonna change. Let's say they only know how to say their name or answer their name. That's gonna be ANO times 1. And then this is gonna go back to asking family, is this normal? Sometimes patients with dementia will not really know where they are. They're gonna be a little more confused, but we need to ask family and say, is that something new? Or is that are they at their baseline right now, is what we say. Are they at their normal baseline level of consciousness? Next in BELLSRP is gonna be S. This is going to be looking at their skin signs again. So we kind of already did this in COPS and circulation, but we just want to double check, make sure that nothing's changed. Again, we're going to be looking at complexion. Are they pale, flush? Are they sweating? Are they dry? And we're also going to be looking at skin temperature as well. Are their extremities or core cold or hot? Those are all going to be important things to mention when we get to the hospital, or obviously treat the patient. If they're super cool, if their body feels cool, you might throw a blanket on them, or maybe they're super overheated. We might want to put some ice packs, on their neck. Typically we do neck, armpits, and groin area to kind of cool them off a bit. Next in our BELLSRP is going to be our R. This is going to be respirations. For this, we're again looking for that 12 to 20 range for adults. Children and infants are going to breathe faster, so those numbers are going to change a little bit. But let's say we're looking at an adult patient looking for that 12 to 20 respirations per minute mark, and you can actually go off of that 15-second mark. You can kind of get a good idea about how fast they're breathing. For this, I typically look kind of right about in this area for that chest rise and fall you'll see on patients. Most are going to be around that 16 respirations per minute mark. Just making sure that they're getting that adequate tidal volume and depth. We don't want them to be taking really quick, shallow respirations, hyperventilating, and we don't want them to be taking really slow, shallow breaths, because then that would be a more severe case where we might have to actually bring out the BVM and assist them in breathing. Next, we are going to check our pulse in BELLSRP. At this point, we're going to check our pulse for a full 30 seconds. And the reason we're going to do that is we don't want to miss anything when we're checking our pulse. So sometimes people will tell you to check it for 15 seconds. I highly recommend not doing that, because what people will do is they'll check it for 15 and then they'll multiply that by 4. I think it's just easier just to do it for 30 seconds, and it's actually better for the patient's sake, just to make sure they're not feeling any irregularities in their pulse, to do it for the full 30. Again, check that radial pulse, typically thumb side. You'll feel it tucked in there a little bit. Get that for 30 seconds, multiply that number by 2, and that will be your pulse rate, or their beats per minute. We're also checking for the strength of the pulse. So does it feel like it's like bounding, you know, out of their wrist? Or does it feel normal? Or does it feel weak, really weak and thready pulse is what we call it? Because again, that could be more issues, underlying issues of what's going on just by checking their pulse. Once all of your vitals are done, you've run through your whole BELLSRP, we are going to be reassessing these in critical patients every 5 minutes, and for less critical patients, every 15 minutes. EMS in general it's not a static system, it's very dynamic. So patients' conditions can deteriorate. You know, someone might seem really normal and then all of a sudden be going into shock or something like that. So we need to be taking that seriously and reassessing those vitals whenever we can. All right, so we're gonna kind of branch off again within our secondary. So if we have a trauma patient versus someone has something medical, medical related going on, we're gonna have a little bit different secondary. We're still always gonna get that sample. We're gonna get our BELLSRP. We're gonna get all of our vitals and everything. But sort of the next steps that we take is gonna be based off what's going on with the patient. So for the sake of this example, I can run through another one, maybe in another video. I'll still kind of give you guys the overview, but I'll go more into detail in this video with a medical patient, because then we're gonna be going through sort of the additional portion of sample, which is going to be OPQRST, the other important, super important series of questions that you're going to be asking the patient. All right, moving on to our OPQRST. You'll notice these questions are going to be very specific to medical patients that are experiencing some form of pain. The best example I can give you guys is someone that is experiencing chest pain. And these questions can actually do a great job at differentiating between something like angina pectoris or someone that's experiencing pain from a myocardial infarction, also known as a heart attack. We're going to be doing an EKG on scene to confirm that, but these questions can be further indicators that help you provide evidence of what's going on with the patient. So the O in OPQRST is going to stand for the onset. For this, we're going to be asking the patient, did their pain come on quickly? So it's going to be sudden onset of pain, or did it come on slowly, which we would consider gradual onset of pain. You can also ask the patient, when did their pain begin and what they think caused the pain. This is going to overlap a little bit with the E in sample, but again, it doesn't hurt to further ask the patient and allow them to provide more information that we can use to treat them properly. Moving on to P. P is going to be provocation and palliation. The questions essentially that go along with this one is going to be asking them if anything makes their pain feel better, does anything make their pain feel worse. You can also ask them how are they most comfortable in their current situation. Next is going to be the Q. This is going to be the quality of their pain. So essentially you're just going to be asking them to describe the pain to you. Usually what I'll do is I'll ask them, can you describe the pain to me? And if they kind of struggle a little bit at first, I'll usually start throwing out some words that might fit their description. So I'll say, is it a sharp pain, dull pain, aching, tearing, anything like that? Usually their pain will fall under one of those. And again, the triage nurse, when you're giving your report, is probably gonna want some sort of descriptor that goes along with this current pain that they're having. All right, moving on to R. R is actually gonna have 3 words that go along with it. We're gonna have region, radiating, and reoccurrence. For region, we're basically gonna ask them, can you point to your pain with one finger, using one finger? They're gonna point to it. Then you're gonna ask them, does that pain move anywhere? Does it radiate anywhere else? And lastly is gonna be reoccurrence. This is gonna be, have you had this pain before? Next is going to be S. S is gonna stand for severity. This is gonna be that classic pain scale that you see in hospitals. We're basically gonna ask the patient, could you rate the pain for me on a scale of 1 to 10, where 10 is the most pain you've ever been in and 1 not so much. Pain's pretty subjective depending on the person, but it's still gonna be super important information to include in your report. Last for our OPQRST questions is gonna be time. And it's exactly like it says. We're gonna ask them, how long has this been going on for? How long have they been experiencing this pain for? When you give your report later at the hospital, you're gonna say, you know, they've been having this pain times 3 hours or 2 weeks or whatever it may be. Moving on to the last main section of this secondary assessment is going to be our either rapid physical exam or our focused physical exams. If you have something like a trauma where the patient might be unconscious, we're gonna have to do a full head to toe rapid trauma assessment on this patient because we don't have them to ask questions about where they're in pain, etc. Even if they are in some sort of severe accident, sometimes, you know, the patient might have, like, let's say a broken arm that's sort of drawing all of their attention to, but they could have some bleed on their leg that they don't even notice. So even in those super severe mechanism of injuries that we arrive upon, we still want to do some form of like head to toe scan on the patient just so we don't miss anything that could potentially be life-threatening. So if this is a trauma injury, like I said, I'm not going super in-depth into it. I'm just kind of giving you guys the overview. I could probably do another video if you guys wanted, but for trauma injuries, we are going to be looking for what's called DCAP BTLS. That's going to be deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and last but not least, we're going to be looking for swelling/scars. So you kind of just have all of those in your head as you're doing your head-to-toe assessment on the patient. Just looking out for those things. Some of them aren't life-threatening and some of them could be. So when you're doing your assessment, especially when you're doing it in front of your instructor in the class, before you start your head-to-toe exam, you're gonna have to voice, hey, I'm looking for DCAP BTLS, as you start at the head and work your way all the way down to the toes. Keep that in mind. You guys are gonna need to verbalize that. And then when you're actually in the field, you're just gonna be mentally going through and looking, seeing if you see any of those. For a side note for you guys, there's gonna be 2 types of patients that are gonna get a rapid physical exam. You're gonna wanna shoot for pretty much like a minute to a minute and a half. It's gonna be very, very quick but thorough. And these are gonna be, like I said, the unresponsive patients and then also major traumas. So unresponsive could be a major trauma, but it also could be some form of medical, like we get a lot of seizure patients. They're typically going to be in some sort of what's called postictal state. So they're going to be a little bit out of it. They're probably going to be altered. Sometimes they're going to be nonverbal and pretty much, for the most part, unresponsive to you. So we're going to want to still do that rapid physical exam on them just to make sure that obviously their airway is intact, because sometimes they bite their tongue, or if they had a seizure, like I said, while they were driving or while they're walking, they might have hit their head. So we gotta check all of our boxes and make sure that there's nothing else going on with the patient that could be life-threatening. But again, the 2 people that get rapid physical exams is gonna be that unresponsive and the major traumas. They're gonna have a ton of adrenaline pumping through their body. The body's gonna be trying to sort of numb whatever pain they're currently having. So you guys got to be thorough when you're going through these assessments. Last but not least, in our EMT patient assessment is going to be the reassessment. This is super important as well, just as important as all the other steps in our assessment, because for this one, we're basically just going to be monitoring the patient and just identifying any changes in our patient's condition. As I said, it's a very dynamic process, and so the patient's condition could look really normal when you get there and everything, but in the ambulance it could get very serious really quickly. So we need to always have an eye on the patient, checking in on them, seeing how they're doing, rechecking vitals. Critical patients every 5 minutes and non-critical every 15 minutes. If you're in a bigger city, you'll probably be at the hospital in less than 15 minutes just because there's so many hospitals in the area. But regardless, we're gonna want to check vitals, run through our primary, secondary again, ask them, is their pain getting any better? If, for instance, the medics gave them any drugs on scene. Questions like that are gonna go a long way, and they're gonna ensure that this patient's getting the best care possible, which is pretty much what that's what we're there to do. Keep that in mind during the reassessment. Thank you guys so much for watching this video. I hope this helps you out in your future EMT endeavors, whatever that may be. If you're currently in the class or thinking about becoming an EMT, this assessment is so great because whatever path you decide to go down in medicine, you're gonna be using some degree of these questions and the assessment. And so this kind of just carries you through, and it gives you honestly this amazing foundation of dealing with patients, asking them the right questions is super pivotal. So all of these things kind of come together and they'll end up carrying with you for the rest of your career, at least if you stay in medicine. If you guys like this video, please like, subscribe. If you didn't like this video, dislike it, but please tell me why and how I can make the video better next time. I'm hoping to bring you guys obviously more EMT content. This is kind of just the start, starting with the assessment, but I definitely want to build upon this. Maybe bringing you guys some videos of specific cases that I've run along, because with each different case, you're going to be asking those different questions to the patient. You're going to be, administering different treatments. And then also maybe I could give you guys like a tour of the ambulance or cool stuff like that. So just let me know if you guys have any ideas, and I appreciate you tuning in. See you guys next time.